Hello, this is Dr. Ed Kim, and in this video podcast, I'm going to talk about how to best teach students and interns effective patient presentations on surgery. And I want to thank Willie Moses, one of our chief residents, for his help on this. So, goals and objectives. The key is for us to establish a common framework for teaching our students and interns. And I understand that many of you might have good and effective ways to teach how to present patients, but it's important that we develop some degree of uniformity so that we can provide consistent feedback and set consistent expectations. And this makes it much easier for the students to learn and for our interns to learn as well. And this will lead for more reliable standards for assessing our learners' progress. When you think about it, the patient presentation is really the hub or the key modality by which we conduct our educational activities. When our learners present patients, that's when we're able to get into their heads and understand how they're thinking, and we can understand what gaps they have in their fund of knowledge or what problems they're having with application of knowledge. And this provides us with opportunities for giving good constructive feedback and also allows us to monitor the progress and the impact of what we're teaching them. A great framework to use is called the RIME framework, which is used at the School of Medicine at UCSF. And RIME stands for Reporter, Interpreter, Manager. And it's basically the idea that when you start at the beginning, your main task and goal to master is collecting the clinical information in a comprehensive, in a complete way without missing big pieces of data that would affect patient care. And then once you've mastered reporter, you go on to become more of an interpreter where you actually are able to prioritize and process the information and in essence provide value-added judgments to the information. This often includes adding qualifiers to the pieces of information and also putting together specific concepts. Manager is when you can start thinking about the treatment options and articulate the pros and cons of each. And educator is when you are able to explain all of this to the patients as well as your own team. So let's talk about being a good reporter and getting a good history. When you talk with students and interns and discuss with them the challenges that they may have in getting a good history, it's really not about interpersonal communication skills. They usually don't have too much trouble developing rapport or getting the patients to open up to them. More problematic actually is not getting all the data, not knowing what's relevant or irrelevant, forgetting to ask important questions about associated symptoms, or not recognizing that there's an important lab value or study that should be noted to be present or absent. So how does one become a good reporter? It's important not to go into patient encounter with a blank slate. A simple, unguided interview often leads to a disorganized, rambling history. You can't just know how to ask all the different things about a symptom, quality, temporal nature, etc., etc. You actually need to be able to focus to gather the information. And it's actually all about reading comprehension. And what I mean by that is that before you go see a patient, you should be able to go to a reference, read the reference, and extract from the reference, and meaning comprehend from the reference, what the elements you need to basically generate a list of questions or list of boxes for information that you're going to want to get from the encounter. So examples of key elements of clinical presentation: what are the reliable findings on exam that you're going to want to look for? What are the labs and studies that are typically ordered for these type of problems, and what the treatment options are? And of course, where the branch points are in management. How do we classify these problems, and where do we make the different decisions whether to do an intervention or not do an intervention? So let's take, for example, when I go see a patient with rectal bleeding in my proctology clinic, this is kind of the schema I have in my mind. I look for key symptoms like bleeding, prolapse, pain. I think about bowel habits and what they've already done with regard to fiber and water intake, and I always make sure that they had a colonoscopy to rule out colorectal cancer, since that's the most concerning thing that we don't want to miss. This schema, which I have because I've had so much experience with all of this, has to be extracted by the beginner from the text or the reference. So in teaching our students and interns to become better reporters, we need to teach them how to go to the reference and be able to read in an effective manner to get the practical information they need before an encounter. You might ask, well, doesn't this lead us to a narrow differential diagnosis that we may miss something in the process? And that is absolutely true. But what you have to realize is that in surgery, we often see the patient at the end of the evaluation process, meaning they often come with a diagnosis, and our job is to be more focused on the treatment, classification, and qualification of the diagnosis rather than starting from a broad symptom. So let's talk about going from a reporter to the interpreter. Now, I'd like you to read these 5 different chief complaints. You'll see that this is about the same patient with acute perforated diverticulitis who's in septic shock, who's on Coumadin for AFib. Obviously, the last chief complaint, the one last on the list, is the most refined and accurate and precise one. And you can see that with each one, there is qualification, value added information, and also inclusion of more pertinent, relevant, important information. And the goal is for us to get our learners to start processing the information rather than just reporting the raw data. And I found that the easiest way to do this, actually, and the simplest way to explain it, is in the writing and the presentation of an H&P. Instead of the classic H&P where they present symptoms and describe quality and character of symptoms in the HPI, and then do the kind of the interpreting at the end in the assessment and plan, what we do in surgery, and what I would recommend that we encourage our students to do since they are on our service, is to use the history and HPI as the part of the history where they pick and choose what they think is important and relevant from all other parts of the history and physical. So what that means is they add things like white blood cell count or CT scan results in the HPI. And you do this in order to narrate a coherent story. You don't have to wait until the end or until the traditional location of that data. So it's an HPI-centric H&P, where the HPI basically serves as a coherent history with all the information, and the concrete act of becoming an interpreter is deciding and choosing which pieces of information are important enough or relevant enough to be put into the HPI. And after the HPI, then the additional information is placed essentially like an appendix to make sure nothing is missing rather than being a key feature. So this highlighting and this prioritization of information is the act of becoming an interpreter. And I think this makes it easier for our learners to understand and easier for us to judge and evaluate whether they're actually doing this or not. So when we're using the RIME framework, of course, observe and listen to the presentation carefully. Decide on whether they're being a reporter or interpreter, starting out with the chief complaint. And then go on to the HPI and see if they're putting all the relevant information there, or they're excluding something, or they've included some things that are not as important, which they fail to understand as being relatively irrelevant. And then with that observation, direct observation, then you can give them feedback and use the language, reporting, interpreting. You did a good job of reporting on this, but you didn't interpret on this. And then be specific. Using the terms, be specific about the content. For example, if somebody mentioned COPD, should it have been in the chief complaint because the patient was on HOMO2? Or should it have been in the HPI because the patient is on home O2, but it's a minor procedure, and so it was unlikely to cancel the procedure? Or should COPD just be in the past medical, since it's just a radiographic diagnosis, or they're relatively asymptomatic from it? So grading the severity of COPD is an important act of interpretation, or grading comorbidities are an important act of interpretation, which we should think about when we're working with our learners. Now I'm going to jump to the second part of this presentation, and the second framework that I want you to think about, and we mentioned this a little bit earlier, is the diagnosis versus treatment focused presentation. In surgery, as I said before, we don't often see people with right lower quadrant abdominal pain as their presentation. We often are called after these patients have gotten labs, have gotten CT scans, and have a diagnosis of acute appendicitis or some other diagnosis that need a surgical problem or surgical intervention. So what we have to appreciate is that the patient presentations are going to be different depending on where somebody is in the diagnostic workup. And what we don't want to do is we don't want to put our learners in a situation where they're out of context, meaning that they will do a diagnosed-focused presentation, meaning even though we know it's a acute appendicitis based on a CT scan, we have them present like we don't know. So for example, if this patient actually already had a CT scan and they presented as somebody who's just presenting as right lower quadrant pain, read the H&P now, and you'll see that this is a very diagnostic approach to this person's H&P, and most likely what's going to happen to this student or this intern or learner is they're going to be interrupted, because we, as a group of physicians and a group of individuals, our culture is to move quickly. We want to be efficient, and it is not, in most cases, we're not going to be patient enough to wait until the end. So we're going to set up our learners for failure if we have them present in this manner. Instead, if we have them present in the way we present, and there's no reason why this is not, that we shouldn't do this, meaning we start with the diagnosis because the diagnosis is set, and we present the pertinent facts, including the CT scan results and the exam results. And also, most importantly, if you read this H&P, you'll see that the patient also is on Plavix, so that should be placed in the HPI as well. If we present in this manner, the learner will much more likely to be well received, much less likely to be interrupted. They'll get their chance to have their say, display what they know, demonstrate what their strengths and weaknesses are in their clinical skills. So using this diagnosis and treatment framework, since in surgery we do see some people who are earlier in the diagnostic workup, and they should be treated more as such with a wider sense of differential and what other possibilities might be with regard to their diagnosis. But if they're more treatment oriented, then we need to do more treatment. We need to be more focused, as illustrated before. But anyways, the learner should basically decide early in the case whether this is going to be a diagnostic focused or diagnosis focused or treatment focused type of presentation. Okay. And this may not be that easy for them to get. They need to learn about accuracy and reliability of specific clinical data. So it's okay to help them with supplemental knowledge. And it's okay also to let them qualify, kind of hedge their bets a little bit if they're not sure, to say this is probable acute appendicitis or possible. Okay? So in summary, let's try to be consistent. It's much easier for our learners, and since you are all learners yourself, you understand how much consistency means and makes a difference in terms of getting better. So for being a good reporter, remember that it's about having an organized approach if you're thinking about symptoms and differentials. But for a lot of what we do, it's about learning about practical information, of a specific disease process when patients come with a diagnosis of a specific disease process. And then being an interpreter means adding value to the information, and the most concrete and the easiest way to explain this and easiest way for us to assess whether this is happening is what information is being placed in the history and physical, what information is being relegated to the past medical, and what information is being placed in the chief complaint. So what and where the information is in a presentation should lead us to understand how much interpretation and synthesis of the clinical data is being performed. And then lastly, remember to have your learners as well as yourself think whether this is a diagnostic versus a treatment-focused case, or whether it's in the middle somewhere. Obviously, it is a bit of a scale, and help guide the presentation and thought process in that way. Thank you very much for listening.